Hi, my name is Brodie, and I'm going to be presenting my DMP project on the effectiveness of shift huddles on patient falls in the ICU. My DMP chair was Dr. Maria Snell. My second reader is Lisa Sturrer, and my community member was Gregory Stahl. Background and significance. Patient safety should be a priority in healthcare. Patient falls are as significant in a patient's outcome as medication errors and hospital-acquired infections. Patient safety should start at the top with management and moves throughout the health system all the way down to nurse techs, respiratory therapists, occupational therapists, physical therapists, and even to phlebotomy. The Patient Safety Network states there are 3 to 5 falls per 1,000 beds daily. More than 33% of inpatient falls result in injury. This project took place in a 42-bed ICU in a hospital in the Midwest region. Since January of 2023, there have been 15 falls in this ICU alone. This is increased from years past. Typical staffing ratio is 1 nurse to 2 patients. This project was completed by an ICU nurse. Patients in a critical care setting are at an increased risk for fall. This can be due to weakness, medications, decreased mobility, and monitors and wires that all affect patients' risk for fall. There is no current fall policy in place that is targeted specifically to the ICU at this facility. Patient falls with injury are in the top 10 safety events in the hospital setting. The Joint Commission received 465 reported falls with serious injuries. 63% of these falls were considered fatal. The Centers for Medicare and Medicaid Services reward hospitals for reduction of hospital-acquired conditions by refunding funds when hospital-acquired conditions are reduced. Review of literature. The key words used for the literature search for this project included safety huddle or team huddle, safety huddle and patient falls, pre-shift huddle and patient falls, and nursing staff and pre-shift huddle or safety huddle. The articles found had 4 common themes, the first being the purpose of the pre-shift huddle, the second being the structure of the pre-shift huddle, the third the effectiveness of the pre-shift huddle, and lastly, the fourth, fall prevention interventions. Huddles are in place to find time for staff to come together and discuss problems that are present in the workplace. Huddles are easily formatted to fit the needs of the situation. They can be altered to fit any unit in the hospital or any problem that may need assessed. Schatz and Bergen state that huddles can create situational awareness, promote staff member engagement, and promote communication. The goal of a shift huddle is most often to promote patient safety, staff participation and satisfaction, and create a positive environment for nursing staff to work in. A huddle is similar to hospital-wide safety rounds, but is unit-specific, focusing on the unit's problems. Theoretical framework. This DMP project relates best to Dorothea Orum's self-care deficit theory. Orum's self-care deficit theory focuses on 3 concepts: self-care, the deficit of self-care, and the self-care agency. Self-care can be described as the practice of activities that individuals initiate and perform on their behalf in maintaining life, health, and well-being. The definition of self-care agency is a person's ability to care for oneself. And lastly, self-care deficit is described when an individual is no longer able to adequately care for themselves. Patients who are admitted to the hospital, specifically into the intensive care unit, are currently experiencing a self-care deficit. The primary goal of nursing should be to meet the patient's needs, increase their capability, or decrease the need for care. Orm's theory of nursing relies on creating a relationship with patients who are receiving care. When staff is creating a plan of care, the patient's expectations of care need to be established. Some patients may have different ideas of what they want their care to be. They may want to move to palliative care. They may want aggressive care. So we just need to keep the patient's best interest in mind. Methods and design. This quality improvement project is a quantitative, analytic, retrospective chart review. To start the process, the unit director presented the shift huddle to the unit charge nurses. Nursing staff was then provided education on the huddle and importance of participation during a staff meeting. The participants of this study included the nursing staff in the ICU. The nursing staff in the ICU consists of the charge nurses who will be completing the shift huddle and the registered nurses and nurse techs. The hospital's electronic medical record was used for data collection. Methods and evaluation. All patient identifiers were removed and not collected for this project. EMRs were used to gather data between February 1st, 2025 and February 28, 2025. This was in the pre-intervention stage. And again in March, beginning on March 1st through March 31st, this was the post-intervention stage. 1 month of shift huddles was completed. This is the project implementation timeline design. So during the planning phase, the researcher looked at the needs assessment, so trying to identify what problem needed to be addressed in the ICU. The researcher collaborated with the director of the ICU to create the project design, along with the community member who worked in the quality improvement department. Starting in November of 2024, facility approval was obtained from the chief nursing officer, and Maryville IRB approval was obtained next. Next, plan for data. The researcher met with the staff to educate them on the project, and the project implementation date was set. During the data collection process, the shift huddle was completed for 1 month by day and night shift. And lastly, results were gathered in April of 2025. The patient census, total patient census for the pre and post intervention period were gathered along with fall rates. The data was then placed into an Excel spreadsheet and then analyzed by the Maryville statistician for project results. Sample. The sample size was the patient census during the pre and post intervention period. The goal sample size set by the Maryville statistician was 154 subjects. Due to the workload of the ICU charge nurse, pre-shift huddles may only be completed some days during the intervention period. This can be due to the fast-paced environment that the ICU charge nurse works in. During shift change, the charge nurse may be on other floors assisting with code blues, rapid responses, or dealing with sick patients within the unit. Data was collected on an Excel sheet each shift. There was one for day and night shift. The data was filled out by the oncoming charge nurse and initialed. When it was completed, it was kept in the charge nurse office in a drawer. If the shift huddle was not completed, it was to be documented the reason why it was not completed. There were 23 shift huddles completed on day shift and 17 shift huddles completed on night shift for the month of March. Data analysis. Pre- and post-intervention fall rates were examined. The pre-shift huddle was completed by the oncoming charge nurse with the oncoming nursing staff to highlight the patients at risk for falling. Additional information included in the shift huddle included patients at risk for fall, patients who were on ventilators, any unusual staffing assignments, any patients with sitters, any patients with telesitters, and the initials of the charge nurse who completed the shift huddle. The number of total patient falls for the month of pre- and post-intervention were recorded on the shift huddle, on the spreadsheet. The total patient census for the month was collected to assess the effectiveness of the shift huddle on patient falls. Results. Descriptive statistics were used to examine the quantitative data. The overall sample size of the study included 468 patients. The pre-intervention sample data was 0 patient falls per 211 patients. The post-intervention sample data was 1 patient fall per 257 patients. Here is a graph or a pie chart of the pre-intervention data. So as you can see here, the red is the number of patients and the blue line, which is 0%, is the number of falls. And here is the post-intervention data. So here we are representing the number of patients in the month of March and the 1 patient fall, which equaled 0.0038%. Results continued. For this study, a lower tail z-test for the difference of two proportions was utilized to determine the significance shift huddles had on patient fall rates in the ICU. With a 95% confidence interval, 95% of the sample mean was within the confidence interval of negative 1.96 standard deviations of the mean. The data for this project unfortunately did not show sufficient results to prove that the shift huddle had an effect on patient falls. Here is the data from the lower tail z-test for the difference of two proportions, resulting in we are not going to reject the null hypothesis. And here are more results. The p-value of 0.8173 is greater than the significance level of 0.05 is not sufficient information to suggest an increase in the ratio from pre to post intervention. The confidence interval suggests the true change from pre to post intervention. Since 0 was included with the interval, there is not significant evidence to show a change in one direction. The achieved power of the study is 0.1976, which is considered low in strength. Limitations. Unfortunately, one of the most significant limitations was that the shift huddle was not completed every shift. There's also a possibility of lack of compliance with the shift huddle. This trickles down onto the nursing staff that were participating in the huddle. They maybe were not bought in on the shift huddle, maybe were late to work, so they did not participate in the shift huddle, or there was an emergency during shift change, so they went out to the floor before the shift huddle was completed. There was a delay in IRB approval. This was a limitation because the patient census in the ICU fluctuates frequently, so there may have been skewed data based on the patient census during the time that the project was complete. The fluctuation in the patient census could change the patient's risk for fall. There are some times when the patient census in the unit is more patients on ventilators, and there are other times where patients are more mobile, up ad lib, transferring from the bed to the chair or the bed to the commode, increasing their risk for fall. And lastly, once again, the workflow of the ICU charge nurse made it difficult to complete the shift huddle. Discussion? The primary finding of this project showed no statistical significance between pre- and post-shift huddle implementation fall rates. The data was recorded each time a shift huddle was completed. Implementing a shift huddle allows staff to come together to focus on an important subject and make the necessary changes. The strength of this study include the retrospective design and the limited number of participants being the nursing staff. Since the ICU is a specialized unit, there are only some nurses who can work in this unit. That includes the ICU staff and several float pool members who are ICU trained as well. Implications for practice. This quality improvement project could be used in the future to improve patient safety. The focus of the shift huddle could be altered to focus on a different topic and used on other floors. The shift huddle could be changed to focus on longevity of patient stay, presence of lines and catheters, and the presence of other specialty devices. Shift huddles could be used in other units or other healthcare facilities. Examples of other units could be surgical floors, looking at pre- and post-surgical infection rates, discharge rates, readmission rates. In conclusion, this quality improvement project has significant potential to change patient safety in the hospital. The results of the data did not show any statistical significance. However, with a longer implementation period, the data may differ. Longer implementation could provide better data. The design of the shift huddle would be easy to implement for other topics and in other units. A change that could be made was implementing the shift huddle in the middle of the shift, giving time for staff to come together and focus on their patient outcomes and patient census. The structure of the shift change could be altered to include the huddle, so they could take an extra 5 minutes to include the shift huddle and shift change and delay shift change altogether. Some things that I learned while working on this project is that the DMP process is very challenging. I learned to expand my research and writing skills and how to find credible data sources to expand my knowledge. And lastly, this DMP project could be completed again to reassess effectiveness. And here are my references.